I recently posted this video on a case of typical myospasm. If you want to understand the diagnosis, the treatment, and the causes of myospasm, this video is for you. The treatment of myospasm, as I always say, depends upon the cause of myospasm. Remember, TMDs are not even disease specific, they are patient specific. The cause of myospasms can be central, as during an episode of stroke. They can be systemic metabolic disorders. They can be local metabolic changes in the muscles involved. They can be overuse reactions. They can be an effect of central excitation secondary to deep pain input. The cause can be even an exposure to cold. The cause of disorder in your patient is reported in the patient's history. Now let's talk about the diagnosis of myospasm. It would be rare that a patient would report to your clinic with an active episode of myospasm. The diagnosis in most temporomandibular disorders is established on the basis of signs and symptoms reported by the patient in his or her history. The patient tells you the problem exactly, but the only problem is that he tells it to you in his own words, and you need to understand and crack the code. The patient not only tells you the exact diagnosis, but they also tell you the cause of the problem and the contributing and perpetuating factors. So, taking a careful history is very important in diagnosis of myospasms. Merely history taking is not enough. You will be able to crack the code in the patient's history only if you know each temporomandibular disorder in depth with the causes that result into them. To begin with, let's understand how we diagnose myospasm from a patient's history by listening to this patient's history. क्या तकलीफ हो रही है आपको?
जबड़ा चिपक रहा है।
चिपक रहा है मतलब बताइए एग्जैक्टली प्रॉब्लम क्या है?
जैसे खाना वगैरह खाते हैं ना तो चिपक जाता है।
ऐसे बंद रह जाता है?
हाँ।
ठीक है। और बंद रह जाता है फिर खुलता कितनी देर में?
ऐसे हो जाती है 3-4 मिनट के लिए।
ठीक है, 3-4 मिनट बाद ही खुलता है। कुछ करने से खुलता है या अपने आप खुल जाता है फिर?
नहीं, ऐसे जैसे अपन ताकत लगाते हैं ना तब खुलता है। ये जॉइंट है ना ये निकल भी जाता है कभी कभी।
निकल जाता है मतलब?
ऐसे जैसे निकल जाता है तो टेढ़ा हो जाता है।
अच्छा।
हाँ।
और फिर बंद हो जाता है अपने आप?
हाँ, मतलब बंद हो जाता है।
ठीक है। जब टेढ़ा हो जाता है तो मुंह खुला रह जाता होगा।
हाँ।
है ना? और टेढ़ा दूसरी तरफ हो जाता होगा।
हाँ, ऐसे
उस तरफ चला जाता है। ठीक है। As you saw, the patient mentions that she experiences a complete inability to open her jaws while eating. But an inability to open jaws can also mean injection trismus, this dislocation without reduction, which is also called as a closed lock. To distinguish these disorders from myospasm, you have to ask leading questions. So when I clarified from the patient answered that she is not able to open her teeth at all, and they are completely clenched together spontaneously when she eats. This is clearly indicative of myospasm. In injection trismus, that is protective co-contraction and local muscle soreness, the patient has restricted mouth opening, but they can open within a limited range. Similarly, in disc dislocation without reduction, the patient can open to within 2-finger wide mouth opening. So this clearly is myospasm. Patient's history and your leading questions establish the diagnosis. If the myospasm involves masseter, temporalis, and medial pterygoid, it leads to an inability to open either completely or a feeling of resistance in opening if the myospasm is less dramatic. In this patient, as you can clearly see, the myospasm is involving the temporalis and the masseter. But wait, pay attention to her complaint that her jaw gets open locked at times. Open lock can occur due to sudden spasm of inferior lateral pterygoid muscle. Since I wanted to know which side inferior lateral pterygoid muscle was undergoing spasm, I asked her if she deflected the midline to the opposing side. When the inferior lateral pterygoid of the right side is involved in myospasm, it pulls the midline to opposite side, that is left side. Her report of an open lock and our leading question helps us confirm that it is a myospasm involving inferior lateral pterygoid muscle too, but this report is less occasional. So this patient is having myospasms that are involving all the masticatory muscles almost. Now let's move on to understanding how I get to the cause of the problem and the contributing factors. The question, how did this problem start, leads you to either the cause of the problem or the initiating event that caused the problem. ये कैसे चालू हुआ?
ऐसे ही अपने आप ही।
अच्छा।
हाँ।
कोई चोट लगी हो?
नहीं।
बीमार हुए हो?
नहीं।
गिर गए हो?
कुछ नहीं हुआ।
कोई बीमारी चालू हुई है जैसे कि ब्लड प्रेशर, डायबिटीज, थायराइड?
ये सब कुछ नहीं है।
कुछ नहीं है। एकदम अपने आप ही चालू
अपने आप ही मतलब ये होने लगा है, पता नहीं।
ऐसा तो नहीं कि ठंड में होना चालू हुआ था?
हाँ, ठंड में ज्यादा होता है।
ठंड में ज्यादा होता है।
हाँ, ठंड में ज्यादा होता है।
इसके अलावा कहीं पे आपको शरीर में सुन्नपन,
नहीं।
दर्द और कुछ महसूस होता है?
नहीं।
कोई और बीमारी आपको?
नहीं, वैसे कोई बीमारी जो दाढ़ निकल रही है ना, जो अकल की दाढ़ होती है ना, वो निकलती है तभी दर्द होता है। तभी ज्यादा होता है, मतलब चिपकना भी तभी ज्यादा होता है। और दोनों तरफ होता है, इस तरफ भी होगा ना तब भी दर्द होगा, इस तरफ वो बंद हो जाएगा ना फिर मतलब कम होगा, जैसे चिपका चिपकी मतलब कम होता है।
ठीक है, एक दिन में कितनी बार चिपकता है?
मतलब कुछ खाएंगे तो
बस, अदरवाइज
चबाने की चीज जो भी खाएंगे ना फिर चिपक जाएंगे।
और अदरवाइज नहीं चिपकता है, मतलब ऐसे ही बैठे हैं टीवी देख रहे हैं और चिपक गया, ऐसा नहीं होता। खाना चालू करोगे
खाना खाएंगे या कुछ भी मतलब खाएंगे ना, मुंह चलाएंगे सो चिपकेगा।
ठीक है। The patient reports that she experiences episode of myospasm every time she tries to eat and every time she feels the pain of an erupting third molar. So in her case, pericoronitis and mastication are initiating factors. Pericoronitis due to an erupting third molar can act as a deep pain input and initiate episodes of myospasm. Please do not confuse them as the cause of myospasm. Understand that a high percentage of general population experiences pericoronitis, but pericoronitis itself is not implicated as a cause of myospasm. It is the deep pain input from pericoronitis that is causing myospasm episode to trigger in this patient. If pericoronitis was a cause of myospasm persistently in a big population, then we will be having patients walking in with myospasm active episodes every now and then. But this is not the case. So here we cannot take pericoronitis as a cause of myospasm, but just as an initiating factor. You can know the cause of the problem only if you know what causes myospasm. So you have to ask leading questions about the central disorders, systemic disorders, overuse, or questions relating to any deep source of pain in the patient's head and neck region. This patient reported to us with degenerative joint disease involving her both temporomandibular joints, with a pre-existing history of clicking of the TMDs earlier. A non-healing temporomandibular joint can be a source of deep pain input to the central nervous system. The central nervous system, under the influence of central excitation, leads to myospasm. Myospasm can involve masticatory muscles, as is being done in this patient. So deep pain input from a non-healing temporomandibular joint is the cause of problem in this patient. But why a non-healing temporomandibular joint? If you see her oral cavity, which you should see at last, you will observe that she has completely attreated teeth. Attretion is just a sign of parafunction. Parafunction, as we all must always remember, is a central activity. Parafunction has origin in central nervous system. It has no relation to occlusion. So, in every case, you have to think deeper and find out the cause of parafunction in this patient. Now, parafunction itself is caused by central excitation secondary to trauma to the central nervous system or central pathologies, due to drug abuse, due to use of alcohol, use of nicotine, secondary to chronic stress, secondary to use of certain medications, and secondary to certain systemic diseases like GERD and obstructive sleep apneas. Again, you have to ask leading questions. Now, if you closely observe, the patient has a traumatic scar on her face, on the forehead, that prompted us to ask her questions related to trauma. She had undergone a road traffic accident and head injury a few years ago. You can relate this head injury with parafunction. So, connecting the dots backward. The patient's head injury led to an increase in parafunction in this patient. Parafunction led to a degenerative joint disease in the temporomandibular joints of this patient. The painful temporomandibular joints are a source of deep pain input that cause central excitation. The central excitation, when it involves the motor neuron that supply to the masticatory muscles, cause myospasm of the masticatory muscles. Once you establish this chain of thoughts, now you are ready to explain it to the patient and to decide the treatment protocol. Since the source of pain is the temporomandibular joint, you have to allow it to heal adequately so that it adapts, comes out of osteoarthritis to osteoarthrosis, which is a stable joint condition that is pain-free. Once the deep source of pain is gone, the episodes of myospasms will stop. The best way to treat a degenerative joint disease involving temporomandibular joints is the use of a permissive appliance for a period of 3 to 6 months. Once this treatment period is over, the temporomandibular joints adapt completely. And once adaptation is complete, you do not need to do anything else to stop the source of deep pain. Understand, parafunction is present in every human being. It is only a lack of adaptability that produces symptoms in any of the patients. Once we have allowed adaptability in the patient and help the joint to adapt, we would not need to do anything else. If at all something is to be done, it is controlling parafunction. Had the parafunction been secondary to drugs or use of alcohol or nicotine or stress, or use of medications, we would have been able to control it. But since it is more related to trauma to the central nervous system, unfortunately, we do not have any control over it. But making the patient aware about it helps, because next time, if the symptoms reappear, a neurophysician will have to be consulted to manage the excitation of central nervous system with the help of certain medications. This patient, however, was completely fine with the use of appliance therapy, physical self-regulation, hot fomentation, since cold acted as a trigger in her, and didn't need any further therapy for controlling parafunction. Hope the video on cracking the code helps you understand the complex chain of diagnosis of temporomandibular disorders. Believe me, it's not difficult. It just takes time, effort, experience, and a willingness to read and understand the subject in depth. Thank you.